Our next interesting talk is from Dr. Hassan Ahmed. Dr. Hassan is a consultant anaesthetist at Leeds Teaching Hospital NHS Trust and an honorary senior lecturer in the School of Medicine, Leeds University. He has been appointed as Associate Professor in the Faculty of Medicine, Cairo, Egypt in 2023. He completed his Fellowship of Trauma and Acute Management from University of Cork, Ireland in 2020, following which he did his another fellowship in cardiothoracic anesthesia and intensive care unit from Royal Papworth Hospital, Cambridge. His special interest areas are cardiothoracic, regional anesthesia, and strong commitment to medical education. So today he is going to give us a very interesting talk on proficiency-based program in labor epidural training.
Thank you so much. Thank you, and thank you for the kind invitation to be part of this meeting. So today my talk will be proficiency-based progression training, a novel approach for labor epidural training. I don't have any financial conflict of interest related to this presentation, and I've been exploring proficiency-based progression training for the last 5 years as part from my PhD. So I've have good experience in the proficiency-based progression training. That's what I can assure you of. So neuroaxial techniques remains the gold standard for labor epidural analgesia, and the epidural catheter placement represents one of the most challenging skills that each novice can face in his first day in obstetric module. And the interesting part is they might need up to 75 attempts to achieve proficiency in labor epidural catheter placement. And this has been based on cumulative sum analysis of trainees or novice trainees who just joined obstetric training in UK. So this report has been published in 2022, which analyzed litigations for anesthesia between 2008 and 2018. And interestingly, there were 1,000 obstetric anesthesia claims submitted to NHS resolution between 2019 and 2020. And obstetric anesthesia was responsible for 14% of the total claims. Claims were related mainly to either failure or repeated neuroaxial attempt or pain during cesarean section. So Macari and colleagues, they reported that medical errors was responsible for the third leading cause of death in the United States, and they reported that preventable harm could be amenable to correction through training. So the question we have, do you think is our standard training is enough? Well, simulation-based training has been part from the standard training nowadays, but there were only limited studies which reported the relation between the simulation-based training and the patient outcome or patient benefit. Gallagher and colleagues, they reported that simulation-based training could be optimized and could be optimal when we tell the trainees, well, there is a proficiency benchmark, you have to achieve this. And as well, if we get able to provide them with an objective, informative feedback. So proficiency-based progression training, it's a way of training in which a trainee should achieve a certain level of proficiency before he passes to the next clinical phase. And this is based on unambiguously defined metrics. So how we define metrics? So basically we choose a scale of interest and a group of experts will meet together and start to characterize this scale. And this is done by reviewing videos of novices and experts doing the scale. And they define metrics, which is a group of behavioral characteristics that together would formulate the procedure itself. And then these defined metrics will go through a process of validation, either content validation, concurrent or construct validation. And after the validation, the group of experts would define the level of proficiency that a novice or a trainee should achieve before he passes to the next clinical phase. And the level of proficiency depends on the mean number of errors that experts could achieve in real life while they are doing the procedure. And then novices and trainees were allowed to practice these metrics in a simulation setting. And this is the whole circle of the proficiency-based progression training. And after they achieve the level of proficiency, they only allowed to go to the clinical practice. So this is in a nutshell, what's proficiency-based progression training, how we develop metrics, how these metrics is validated. So this study is from the North Arthroscopic America Association. So this was a multi-centric study exploring proficiency-based progression training. So when it was developed, the proficiency-based progression training was developed in Yale in 2002, when a group of surgeons and psychologists, they said, well, we have to improve the simulation training, and they concluded that proficiency-based progression training is associated with a less number of errors in a simulation and in a clinical setting. So in this study, the surgical skill subcommittee asked the question, is there a better way to train surgical skills? So in this study, they tested the pancake procedure, which is an arthroscopic procedure for shoulder joint instability. And it was a multi-centric study, prospective, randomized, double-blinded, from 21 centers in the States. They invited 44 trainees to join this study, and they randomly allocated them to 3 groups. Group A will have the standard training, Group B simulation only, and Group C will go through the proficiency-based progression route. All of the groups were provided by orientation video, and visual spatial characteristics were collected from all of the groups. So in Group A, they only trained on how to tie a knot, basically. Group B were allowed to practice in a mannequin. Group C, practice on a mannequin, but they have to reach the proficiency level before they pass to the 3rd stage, which is practice this procedure in a cadaver. So you can guess the results. So the traditional training achieved the highest number of errors in the recorded videos, and the simulation group, fewer, and the proficiency-based progression group has the lowest number of errors in a simulation setting in a cadaver. And the surprising here, it's only 30% of the people who received standard training achieved proficiency, which is the lowest number of trainees achieving proficiency among the 3 groups. So this study has been done by a group of researchers in Ireland. This was the first study to explore proficiency-based progression training in labor epidural analgesia. And so they developed, validated, and tested the effectiveness of proficiency-based progression training. So again, they have developed the metrics for it, okay? So a group of 3 experts have met 5 times, face-to-face meetings, and they started by reviewing videos done by experts and novices from real life. And by analyzing these videos, they describe a very detailed set of metrics which formulate the whole procedure of the labor epidural catheter placement. And then this group of metrics have gone through a process of validation, and they have done a constructive validation by reviewing videos from experts and novices, and they started to mark these videos using the defined set of metrics. And while reviewing this, they have defined the proficiency level that each novice should attain before pass to clinical setting. And here it was that he should not do any critical errors, okay, and less than 16 non-critical errors. And when they define the critical errors, they are errors which could result in actual patient harm. And non-critical error is a deviation from the optimal performance, but in fact it will not result in actual patient harm. So they define 72 metrics or detailed steps. These are sampled from the metrics, and the one color with the red color, you see, it would really result in fact, patient harm, actual patient harm. For example, pulling a catheter through a needle, or manipulating the needle while the catheter is inside, or advance the needle over the catheter at any point. And then they tested the effectiveness of this way of training by randomizing a group of novices between a simulation group and a proficiency-based progression group. So, and then they followed the epidural failure rate of these novices. And they used the previous definition, or the standard definition of epidural failure rate, which is termination of the procedure, supervisors take over, accidental dural puncture headache, or failure to achieve analgesia within 60 minutes from the insertion of the epidural. Sorry. And the primary outcome was a comparison between both groups in terms of epidural failure rate. The outcome of epidurals was objectively documented by midwives. And the secondary outcomes were patient satisfaction and impact on training of clinical performance. So the epidural failure rate, so first of all, there was no differences in the visuospatial characteristics of the novices. And the primary outcome was epidural failure rate was in the simulation group 28% versus 13% in the proficiency-based progression group. So there was almost 50% reduction of the epidural failure rate in the proficiency-based group in comparison with the simulation-only group. So the question we have now, do you think is it only research work and it could not be implemented in real life? Can we achieve proficiency-based progression training in a very busy tertiary hospital? So this study has been published and done by our group in the IJOA in 21, in which we tried to implement proficiency-based progression training as part from the standard training in labor epidural catheter placement. So our objective was to test for the feasibility, implementation steps, and resources essential for proficiency-based progression implementation in a tertiary hospital. So this is a core slide. How did we develop? How did we implement this? So first of all, we got stakeholders in our sites. So we tried to convince everyone. Well, this is our work. We need to implement this, and we will get a huge patient benefit from it. And then we identified trainers, and we developed a train-the-trainer course in which experts were introduced to proficiency-based progression training and how to develop it. And then we done a dry run about it before actual training of the trainees. In the training phase, so all of the trainees were scheduled to start the obstetric module in a calendar year have been included in this study. And we collected the visuospatial characteristics of these trainees as well. We provided them with study materials, and 2 weeks before the proficiency-based course, and they only allowed to attend the course if they passed the MCQ test with an 80% pass mark. In the event that they didn't pass the MCQ test, we provide them with more time, and they will go for a retesting again. And then they will have a proficiency-based progression course with one of the experts. It's one-to-one course in which they will be introduced to the metrics, how to do the metrics in a simulation setting, and we show them videos from real life about errors to avoid, non-critical errors to avoid as well. And then they will be allowed to practice on a mannequin how to put a labor epidural catheter. And when they are happy and satisfied with the practice on the mannequin, they are allowed to practice a start to finish procedure. And this has been marked by one of the experts. And they are not allowed to pass to the clinical phase unless they didn't do any critical error and less than 16 non-critical errors. So, and then they are allowed to pass to the clinical setting within 2 weeks, and we followed up their epidural, and we followed the patient satisfaction as well. So in the clinical phase, we managed to include 12 trainees, which have been trained in proficiency-based progression training. And we managed to, so one trainee has been excluded, so 11 trainees to follow up their epidurals. And we followed up 180 epidurals in a calendar year, has been followed up and analyzed. So the epidural failure rate was reported in this study by those trainees as 12%, so 22 out of 180. And when we compare it to the literature epidural failure rate, which was 23%, so we achieved the same result, which is 50% reduction in epidural failure rate to the same study which has been done in the research setting before. So, and this is a patient satisfaction. We achieved a very high patient satisfaction, more than 80% in terms of epidural performance satisfaction and quality of pain relief. So we conclude in this study that with only limited resources, we can implement proficiency-based progression training in a tertiary center in real life, basically. So we only needed for this just very limited resources, mannequin, expertise in proficiency-based progression training, and a suitable training room. So is the proficiency-based progression training implemented elsewhere? Is that involved in any other skills? So this is a systematic review and meta-analysis about proficiency-based progression training in other skills. It has been published in 21. So they end up by analyzing 11 studies, And it included other variable skills like laparoscopic cholecystectomy, carotid artery angiography, coronary angiography. From the anesthetic side, it included the labor epidural, catheter placement, axillary nerve block, and even in non-clinical skills, which is communication and handing over of a deteriorating patient. And they concluded, well, all of these studies favoring proficiency-based progression training in comparison with standard training. So what we are trying to do, at least what we are doing in Leeds at the moment, is to implement this way of training as a standard way of training in real life. We started in September last year, and we managed to train 8 novices. 7 of them have proceeded to the clinical phase, and we followed up their epidurals. Up till now, they have done 47 epidurals, and 4 deemed to be failed. So failure rate was reported as 8.5%, and plan is to train more on proficiency-based progression training. Well, thank you so much, and very happy to have you.
Any questions?
Hi, I'm James from York, one of the consultants. I've, in my training, rotated through 11 or 12 hospitals within Yorkshire, and everybody does it differently.
Yes.
So, I buy into what you're saying. Do you think it should be a standardised teaching approach rather than this is the Leeds way, this is the whole way, this is the York way?
Well, I would say the main benefit of the proficiency-based progression training, it's standardized. It could be definitely tweaked to fit in the center. So these metrics have been developed in Ireland initially. So to implement it in Leeds, we have to tweak a little bit of the steps, okay? So, for example, well, they don't do in Leeds betadine, they only do chlorhexidine. In Ireland, they do betadine. So we have to change a little bit to fit in the center. But the main benefit of it is standardization and objective feedback that you can give to your trainee. So, for example, if you have 2 trainees, both of them are doing epidurals, and both of them managed to do the epidural, but they are doing it differently. And there's deviation from the optimal performance in post, or one have done it completely right, but other one, well, I did some steps. So the good thing about the proficiency-based training is you can provide him with objective feedback about the specific steps that he didn't manage to master, and he need to master the next time. So it provides objective feedback, it provides an ability to push your trainee to achieve a certain benchmark to achieve proficiency. Did I answer the question?
I think so.
Not entirely.
Yeah. I think in an ideal world, yes, and having those metrics to educate them. The difficulty is that we're getting trainees at very different stages.
Yes.
And I think when you get them at Leeds, they're at least registrar, so they've already been taught a variety of different techniques.
That's right.
So are they better to remain on a technique that they're comfortable with, or do you then encourage them into doing it your way?
Yes. Well, these studies, all of these studies has been tested on novices who has no previous experience at all in doing this. We didn't test it on experts, basically, or, well, when you have a trainee who have done more than 100 epidural, and now you want him to change his practice to this, it might be tricky, and we didn't study this at all to teach experts. But what we got from trainees is that it helps them to improve their technique, and it helps them to avoid errors which has been done before in clinical setting.
As consultants, institutional help. Do you think we're at the stage that we can produce some sort of essential guidance for epidural placement, obstetrics?
Yes,
and some like optional measures, because I think we all following similar steps, but somebody will say, "Oh, this is you have to do it," and someone will say, "No, you don't need to do it." But do you think? Like,
well, the aim of this, Well, the aim of this is to standardize the training, basically, and this is what we are trying is to standardize the training, and all of the novices are trained the same way, and all of them have studied the metrics, performed it, and know what to avoid. and it's like a driving test. It's ticking the box basically. If he tick all the boxes, he passed. If he didn't, so he should master the following steps to go. Well, this is what I think. It should be standardized, and the feedback which we really get, in addition to the patient benefit and patient outcome, is really very good about this way of training.
Any other questions? I have a question.
Sure.
So you were saying about the experts. So how many years of experience these experts have?
So in the studies which we have done, okay, so we involved consultants, anesthetists, who have done more than 100 epidural a year for the last 5 years. So more than 500 epidurals, and they have completed their training, and they are in fact practicing in the labor epidural ward at least twice a month.
Okay. You just mentioned that obviously you've started this training program in Leeds.
Yes.
Any challenges with this training program you have faced?
Yes, well, in fact, well, definitely there are some challenges, okay, and to implement any implementation of a change, there are lots of challenges, but the one which we have in Leeds is we got most the trainees at advanced level, so we usually got as registrars, so they have already practiced epidural and they have learned their own way, either by saline, intermittent pressure, or air, so we only include novices in these studies. So this is one of the challenges. Otherwise, we've trained up to now, I think, 8 novices. So before they start to go to the obstetric module, they just have a training session with one of the experts, one-to-one, on a mannequin. They practice the metrics. They have provided with the theoretical materials beforehand, and they've done the MCQ test. And all of the trainees are very compliant to it. And the feedback which we got from them after they finish, they are very happy with it.
Hassan from I was just wondering, how long does a novice trainee take from being incompetent to get complete competency in this skill?
In this skill, well, the epidural. Well, we only followed the first 10 epidurals of them. After epidural number 10, studies reported that the usual success rate is almost steady after 10 epidural. And so the epidural failure rate which we got reported 50% reduction in the reported one. So we are hoping, well, in the reported studies beforehand, in cumulative sum analysis, they reported up to 50 to 75 epidural to achieve proficiency. What we got from our trainees in the first 10 epidurals, less than around, it's 8%. So it's 2 in 10 basically.
I just wondered, you say you followed up the first 10. Were all of those 10 clinical ones
Yes.
supervised in the room by an expert?
Well, we leave the supervision of the catheter placement to up to the consultant who is in charge for this. So we don't oblige the consultant to supervise them. It's just the normal practice which we do. Okay. So we as well measure the supervision level of them. Okay. So, but they are all clinical ones. But we will leave the supervision to the dissertation of the consultant who is responsible for them.
So you don't have a minimum, so they could be doing their first ever epidural on a patient.
We leave this up to the
and
normal
not have
practice.
anybody else in the room unless they call for help.
Yes, exactly. So it's the normal practice.
Hello, good morning. I'm Kruti from Halifax, CHFT. Could you give us an idea, thank you very much for that very interesting talk. Could you give us an idea as to what kind of visual-spatial characteristics you standardize for while recruiting trainees to your training program? That's part A of the question. Part B, did you or did you not consider any variation in fine motor skills as well?
Sorry, what's this part B again, please?
So the part A is what kind of visual-spatial characteristics did you standardize for while recruiting trainees to your program? You mentioned you standardized trainees for visual-spatial characteristics.
Right.
What kind of visual-spatial characteristics did you standardize for?
Okay.
Part A. Part B, did you consider any differences in fine motor skills?
Okay.
Between the trainees?
So basically, we all of trainees, all of novices are being invited to participate in this training program. And when we define novices, they have done less than 50 epidurals and they have less than 2 years of experience in anesthetics. So all novices are invited. We don't standardize the characteristics for them, but we measure it as part from make sure that, well, to eliminate any differences between trainees. So we ask them to complete card rotation test. We ask them to complete a sheet about their characteristics. Are they right-handed? Are they left-handed? Do they wear goggles or not? And we provide them with other tests to make sure at the end we analyze this, make sure that they are a homogeneous cohort of trainees. So we test them in terms of card rotation test, a Dempera handedness test, and other characteristics like handedness and if they are using goggles or not. But we don't standardize them before we recruit them, basically.
Okay, thank you.
Hello there, it's Paul from Leeds. We've identified that differential attainment is a challenge when training. So trainees from different backgrounds encountering different rates of attainment, if you will. Do we think this technique could be a way of closing that gap?
Well, we are hoping so. It is objective and to be it's objectively defined, and we're hoping it would definitely reduce the gap between the different backgrounds and novices. So when this study has been done initially in Ireland, so post studies about the developing and the implementation, we included trainees from all backgrounds, and post achieved more or less similar results in terms of epidural failure rate. So this has been proved before and validated. Well, it's not specific for a specific cohort of patients, but taking consideration these studies only were for novices, not for experts. So we didn't train, for example, trainees who had 10 years of previous experience and they are working as medical consultant jobs, and they have done more than 100 epidurals.
Pardon me, so if somebody had practiced in a non-UK or a non-NHS setting, would you recruit them for your study? So you would have done, if they've done epidurals in other healthcare settings?
Yes, if they are novices, I've done less than 50 epidurals, yes, they are invited to definitely participate.
Okay, thank you.
Hi, it's Andrew from Bradford here. Just a quick question on the progression. So it said that for the ones in the progression, basically they have an MCQ, they've got materials, they have to pass that to move on to the next step. Has anyone ever looked at just giving them materials and giving them an MCQ and letting them progress anyway and see if that's what's making the difference rather than these roadblocks that they don't meet a certain standard?
Yeah, so what from our experience and my experience in doing this for the last 5 years, usually they pass more than 80%. Only few numbers of trainees didn't pass, and we provide them with more time to study. So basically they didn't read the materials and they got through the MCQ and they got 40%. And obviously they didn't even bother to read it. So we give them more time to read the materials and we submit them with the MCQ exam again, and it's 100% pass rate.
Any other questions we have?
How do trainees feel about it?
Very good. All of the feedback we got, it's very good. They sometimes feel a bit stressful at the end part when they are allowed to do this procedure start to finish without interruption on a mannequin. So sometimes they feel stressed about it, but at the end, and especially the feedback you got with the first epidural they put, well, this is really very good, and it saves them a lot of effort and while doing the first epidural in a clinical setting. So to have the stress doing it in a simulation setting is far away better than to have it in first epidural in a clinical setting.
Any other question? Okay, thank you so much.
Thank you. Thank you so much.